Hi, my name's Jacob. I'm a final year medical student at Lancaster Medical School. So this is episode number 2 of the Cardiology series. Previously, we looked at an introduction to ischemic heart disease, but today we're going to go into a little bit more detail about angina. So we're going to look at the classification, going to look at some of the pathophysiology, clinical features, investigations and management. Okay, and I'm going to walk you through step by step. I've got some good tables and diagrams, what might help you, what you might find useful in making this topic a bit more easy to grasp. Okay, and before we get right into the video, I just wanted to mention, since my previous video, I've had some really positive feedback, whether that's and that's been kind of people coming up to me and saying, I've found it useful, or it's helped me with this topic. Or I like the idea of what you're doing, and all them comments I really, really appreciate, 'cause it motivates me to do these videos, and it means that you're finding these useful, which means a lot to me. So with that being said, let's get right into this video. So we're going to do a little a recap of ischemic heart disease, and if you haven't already, watch my introduction on ischemic heart disease, and that'll bring you up to speed. So we've got some definitions. So angina is chest discomfort when the myocardium, the muscular layer of the heart, doesn't receive enough oxygen. And then we have the two conditions, what we're going to be talking about today. So we have stable angina and unstable angina. Unstable angina, remember, is part of acute coronary syndrome, which also includes NSTEMI and STEMI, which we're going to talk about in the next video in more detail. Okay, so stable angina, sudden onset chest pain resolving with rest or GTN spray, and it should typically resolve within 5 minutes. Okay. Right, and then these are some of the symptoms which acute coronary syndrome can present with. You're probably familiar with these. So chest pain can present as a heaviness behind the sternum, which can move to the jaw, neck, or left arm typically. And then we have other symptoms such as sweating, shortness of breath, lightheadedness, even vomiting, and the patient can look quite pale. We're also going to talk about this again, about the degree of vessel occlusion, related to the severity of the symptoms. And I've got some good tables which explain this for stable angina and unstable angina. Okay, let's move on. And then I've just got another slide here just to remind you of some of the modifiable and non-modifiable risk factors. Remembering from the modifiable risk factors that smoking is the most important, and that if you stop smoking, your risk of having a cardiovascular event such as a heart attack halves after a year of stopping. And then you also have your non-modifiable risk factors here. So these genetic conditions which might result in your cholesterol being at dysregulated levels or high, and then certain ethnicities where there's a higher prevalence of conditions such as type 2 diabetes and hypertension, risk factors for developing angina, and also risk factors for future cardiovascular events. Okay, so we're going to talk about the pathophysiology of angina, because there's different underlying mechanisms of how it can occur. So one of them is there can be restriction of blood flow in the coronary vessels due to stenosis or atherosclerosis. Stenosis means narrowing, and then we discussed, and that can be due to atherosclerosis or thrombosis, which we mentioned in the previous video, that thrombosis was of blood due to the clotting of blood. And then we also talked about the pathophysiology of atherosclerosis as well, how you get formation of a fatty atheroma, and that can narrow narrow the diameter of the coronary vessels in which blood can get past. And then we have some other mechanisms. So there can be increased resistance or constriction of the coronary vessels. I think that should say or. And this constriction's inappropriate. Certain drugs can cause constriction of the coronary vessels, and this can reproduce that chest pain. And then the final mechanism, so there can be a reduction in the oxygen carrying capacity of the red blood cells. So we're going to talk about the classification of angina. So I've mentioned already today we're going to be talking about stable angina, unstable angina, and then there's this other variant called Prinzmetal's variant, and I've just kind of added that for your own, just as a bit extra, and we'll talk about that as well. So we've already mentioned that in stable angina, the pain is typically less than 10 minutes. It's relieved by rest or the GTN spray. And it's brought on by activity. And when I say it's brought on by activity, that could be after you've eaten, that could be stress, emotional stress. It could also be exercise, for example. And then we have the definition of unstable angina, so pain greater than 10 minutes, not relieved by rest or GTN, and the pain can typically, it typically occurs at rest, unlike stable angina. And then Prinzmetal's variant is due to vasospasm. So vasospasm of the coronary arteries, and this is quickly relieved by GTN spray. But Prinzmetal's variant is, often confused for more serious conditions such as NSTEMI and STEMI, because the cardiac enzymes such as the troponins and the creatinine kinase can be elevated, and there can also be some ST changes, so there can be some ST elevation or there could be some ST depression on the ECG. However, these changes are transient and tend to resolve sooner than the more serious conditions such as STEMI and NSTEMI. And then we're going to talk about the coronary arteries in stable angina. I think I might have mentioned this in the previous video. So you have roughly about 50% stenosis in stable angina, 70% stenosis in unstable angina. And then, like I've just said, Prinzmetal's variant, it's a vasospasm of the arteries. So it's not a stenotic process. And then in terms of the ischemia, in stable angina, it's subendocardial ischemia. So oxygen is the subendocardial layer, so the layer just beneath the endocardium. So the endocardium is where the heart valves are. So just below that is being deprived of oxygen. And that's not as serious as when you have transmural ischemia in unstable angina. Transmural means across all of the layers. So the endocardium, the myocardium, and also the epicardium, parts of the epicardium as well in unstable angina. And that's because the arteries are more stenotic, therefore the blood flow is impeded more. And then if we look at Prinzmetal's, there's transmural ischemia, and you can even have some myocardial necrosis. So necrosis just means death of the heart cells, the cardiomyocytes. Okay, so that was the classification. And then we can talk about some investigations and diagnosis. So we'll start with stable angina again. We want to do an ECG to rule out more serious causes. And for example, if someone presented to their GP, the GP could make a clinical diagnosis and give them some GTN spray when they have an acute attack of angina. but they would also need a rapid action chest pain clinic referral, so that more investigations could be done and the patient could be educated about their condition, and what to do if their condition worsens. Okay, so we'll talk about unstable angina. So again, we do an ECG. In unstable angina, you don't typically have ECG changes, such as ST elevation or depression, but the cardiac enzymes may be raised. They may be raised, but not as much as something like an NSTEMI. And then what you'd want to do for Prinzmetals is an ECG again, to rule out other causes, and then you'd want to basically try and find evidence of this coronary artery vasospasm, and you can do this by using angiography. So it's a type of imaging which helps you to look at the arteries of the heart and observe them in time to see if they're going through this vasospastic process. Okay, so stable angina and unstable angina are clinical diagnoses, but to diagnose Prinzmetals, they can sometimes do exercise stress testing, and the patient will be hooked up to an electrocardiogram, an ECG, and they can look for these ischemic changes on the ECG. Cardiac catheterization is also important because it helps to rule out atherosclerotic process and narrowing of the coronary vessels as an alternative cause. Okay, so we're going to talk about the management of stable angina now. So the first thing you should always think about in management is lifestyle modification, and we can look at these modifiable risk factors. For example, if the patient has diabetes, we can optimize their glycemic control. We can refer them for services what can help with them to stop smoking. If they're anemic, we could try and encourage them to have a diet what has more iron. That might be useful for that. And then we can also encourage them to lose weight if necessary. And then we move on to our pharmacological management. So I've been talking a lot about GTN spray, and this is used in acute attacks when they have these acute episodes of chest pain. And how that's used is it's a spray, and you tell a patient to lift their tongue and spray the GTN under their tongue. You can do 2 sprays, and then you wait 5 minutes. If the pain is unresolved, you can do another 2 sprays, and if they still continue to have chest pain, it's important to then call an ambulance. And the reason it's given under the tongue is because there's lots of blood vessels there, and it really helps to get that medication into the systemic circulation quickly, so it can have an effect on dilating them coronary arteries and alleviate the patient's symptoms. Okay, and then if pharmacological therapy has failed or isn't tolerated by the patient, other surgical options such as coronary angiography, acting as a guide for other procedures such as percutaneous coronary intervention, PCI, or a coronary artery bypass graft. Okay, so let's look at the pharmacological management of stable angina in a little bit more detail. Okay, so if someone has stable angina, we want to prevent. We want to look at prevention, secondary prevention, because they have stable angina, but we want to prevent them from developing other cardiovascular complications, such as having an MI. So these three medications are important, and I've put the doses as well, just because I feel like they're important for you to know. I had a look on the BNF, and these are the doses what they use for secondary prevention of cardiovascular events. So we have aspirin, 75 milligrams once a day, atorvastatin, which helps to lower the low density lipoprotein, the bad cholesterol, and then for acute attacks, I've mentioned this quite a few times now. We have the GTN spray. Okay, and then we need to look at first line medications. So you can either use bisoprolol, which is a beta blocker, and what this aims to do is it lowers the heart rate and reduces the amount that the left ventricle has to work. Or there's another medication called verapamil, which primarily acts on it's a calcium channel blocker, and it primarily acts on calcium channels which are cardiac, because you can have calcium channels elsewhere, and that's the site for other calcium channel blockers, which I'm going to mention. And then we move on. The patient can move on to dual therapy, so they might have another medication started. And if you're using bisoprolol, okay, we've got verapamil here, which is a calcium channel blocker, and we have nifedipine, which is a calcium channel blocker. But if the patient's using bisoprolol, you'd want to start nifedipine, because nifedipine acts on peripheral calcium channels, so calcium channels on blood vessels, helping to reduce systemic vascular resistance. What you wouldn't want to do is combine bisoprolol and verapamil, because they both act on the heart, and that can potentially lead to things like heart block. So you mustn't use bisoprolol and verapamil together. And then if the patient is unable to tolerate awaiting revascularization, so PCI, or isn't a suitable candidate for revascularization, there are other options we can look at. So we can look at other medications such as isosorbide mononitrate, which is a long-acting nitrate. So GTN spray was a short-acting nitrate. Isosorbide mononitrate is a long-acting one. Okay. And then we have ivabradine, which acts on they're called funny ion channels of the heart, and that basically just helps to reduce the heart rate, essentially. I think the pathophysiology, sorry, the mechanism of action is a little bit more is a little bit more complex than that. And then we have nicorandil, which is a peripheral and central vasodilator. And then lastly, we have a medication called ranolazine. And if you were looking to start these medications, it'd be under the experienced advice of one of the cardiologists. And then we need to talk about unstable angina acute management. So the management pathway, what I'm going to show you is it's a common pathway for acute coronary syndrome, because that's what unstable angina is included in. And this diagram here is just to reiterate how GTN spray is administered. So under the tongue, you can see these. You can see all the vessels here, the abundance of vessels. So first thing you need is the patient has to be urgently admitted. We give 300 milligrams of aspirin, so high dose aspirin. Oxygen, if the patient's saturations are less than 94%. You can also give oxygen if the patient is visibly breathless. That can be another reason to give oxygen. If they're in pain, you can give morphine, give intravenous morphine, and milder pain can be managed with paracetamol. And then we're also going to give sublingual or even intravenous nitrates to try and dilate them coronary vessels and improve the blood flow. But you just have to be quite a little bit careful when the patient has low blood pressure. You don't want to lower the blood pressure too much, because it might cause them to become confused and cause altered consciousness. In other words, they might faint. Okay, and then lastly, we need to consider if the unstable angina could progress into an NSTEMI or a STEMI, and this is if the symptoms last greater than 20 minutes, or you have some positive ECG changes of NSTEMI or STEMI in 2 or more leads for greater than 20 minutes. So that's something to be aware of as well. The patient's situation can deteriorate, so you have to be aware of these signs. These signs if that does happen. All right, okay. And I just thought I'd mention some differentials of angina. Some of these conditions I've got here we're going to discuss in more detail in future videos. So myocardial infarction, we're going to discuss that in the next video, and how to differentiate an MI from angina. And then we have gastroesophageal reflux disease, pericarditis, which is inflammation of the pericardium, which surrounds the heart. We've mentioned in detail in this video about Prinzmetal's variant. Another differential is musculoskeletal pain, whether that could be a rib fracture, or following a viral infection, patients can have something called costochondritis, which can present as similarly to angina. And then the last differential is aortic dissection. So that's when you have tearing of the tunica intima of the aorta. But again, this would present with chest pain, but the nature of that chest pain would be different. And all of these conditions I'm going to be discussing in more detail in future videos, and how you can exclude them from your most likely diagnosis. And that's a very important skill. Which you have to learn. But you get a lot of practice doing it, so eventually you become better at it. So that concludes episode 2 of the cardiology series on angina. I hope you found this video useful, and like always, remember to like and subscribe, and check out the link in my bio to access my personal notes, which I've used in medical school and helped me a lot with my theory and practical exams. But once again, really great to hear some good feedback on these videos, and yeah, I hope you find this useful, and I'll see you next time. And next time we're going to be talking about NSTEMI and STEMI in a lot more detail. Okay, so thanks for watching. I'll see you later.